Absolutely. Our first paper will be stroke death ratio as a measure to gauge reporting of outcomes following carotid revascularization. Dr. Schermerhorn and colleagues.
Thank you for the opportunity to present our work. Administrative data have been used to compare outcomes of carotid endarterectomy and carotid artery stenting, but concerns about the accuracy of these data sets persist. A key issue is the reliance on non-specific ICD codes, which are prone to misclassification and can lead to inaccurate reporting. For example, studies using administrative data reported 92% to 97% of patients undergoing carotid revascularization are asymptomatic. Given these limitations, it's likely that perioperative complications, such as stroke, are not accurately captured. We hypothesize that death is reliably captured in both RCTs and real-world data, whereas stroke events may be underreported in real-world settings. To investigate this, we analyzed the stroke-to-death ratio across different data sources to assess the completeness of stroke event capture. This study is a narrative review with a secondary analysis of real-world data from VQI, NSQIP, and NIS. For each procedure, we calculated the in-hospital and 30-day stroke-to-death ratios, stratified by symptom status. It's important to clarify that we are focusing on stroke-to-death ratios, not stroke or death rates. We presented the stroke-to-death ratios descriptively along the weighted ratios of RCTs. So to demonstrate, the stroke-to-death ratio was calculated by dividing the stroke rate by the death rate across different data sources. Before we move into the results, I would like to briefly address some data limitations. For the NSQIP and NIS databases, we were unable to differentiate between the types of CAS procedures. In case of the VQI, we were only able to report reliable in-hospital ratios. Lastly, for RCTs, we could only provide 30-day ratios. This table shows the proportion of asymptomatic patients across the different data sources. As you can see, there's a lot of variation here with very high rates in NIS. This table displays the in-hospital stroke-to-death ratios following CEA across various data sets. Overall, the ratio is 4.7 in NSQIP, 3.5 in VQI, and notably lower, 2.1 in NIS. For asymptomatic patients, the ratio is 5.5 in NSQIP, 3.4 in VQI, and 2.2 in NIS. In symptomatic patients, the ratio is 4.3 in NSQIP, 3.5 in VQI, and 1.8 in NIS. And these are the 30-day stroke-to-death ratios following CEA, and overall, the weighted ratio from RCTs is 6.4 compared to 2.4 in NSQIP. For asymptomatic patients, the weighted RCT ratio was 3.9 compared to 2.3 in NSQIP. In symptomatic patients, the ratio was 6.3 in RCTs and 2.5 in NSQIP. This table represents in-hospital stroke-to-death ratios following TF-CAS or CAS. Overall, the ratio was 2.1 in NSQIP, 1.5 in VQI, and 1.7 in NIS. In asymptomatic patients, the NSQIP ratio was 5.0 compared to 3.2 in VQI and 2.3 in NIS. And for asymptomatic patients, the ratio was 1.1 for both NSQIP and VQI and 0.8 for NIS. Regarding 30-day ratios following TF-CAS or CAS, NSQIP ratios were notably lower than those of RCTs, with a weighted RCT ratio of 5.2 overall compared to 1.3 in NSQIP. In asymptomatic patients, the weighted RCT ratio was 15.7, and that high ratio is largely due to the low mortality rate in the ACT1 trial. In symptomatic patients, the weighted RCT ratio was 8.4 compared to 0.7 in NSQIP. For TCAR, only in-hospital ratios from VQI were available. So in conclusion, RCTs, where neurologists are involved in stroke assessment, remain the gold standard for accurately capturing stroke events. While VQI and NSQIP may miss some minor strokes, they still provide valuable insights for research and patient counseling. Although administrative data can highlight broad trends, they should not be used for assessing stroke rates. We propose using the stroke-to-death ratio as a tool to identify underreporting, with efforts aimed at improving data accuracy. Thank you for your attention.
Great. This paper is open for discussion. So I'll start it. It sounds like you're trying to introduce yet yet sort of another metric. And actually I had to squint to see we weren't talking about stroke and death. Stroke to death sounds almost the same. And I'm just curious, just as this gets out into the literature more, about how you see folks will be using it, or how it could be misquoted as stroke to death, number of 15 in an asymptomatic patient, without sort of delving into the details of it. So where do you see this fitting in? Because everybody understands stroke and death, right? You talk to a patient, you talk about stroke and death, but a ratio, I think, is a little harder to clinically apply. So I'm curious your thoughts about that.
Yeah, so we descriptively compare these ratios just to show that they're very different. And I think there is probably underreporting in NIS. I think those differences can also be attributed to probably low mortality rates in RCTs because they're selecting more healthy patients. But alternatively, it might be a result of poorly or inappropriately selecting patients in real-world settings where high mortality rates can result in lower stroke-to-death ratios. So I think we need to account for these differences and in interpreting this ratio.
Great.
Dr. Jordan?
Will Jordan, Augusta, Georgia. Congratulations on your presentation. It's reminiscent of a message that we got from a stroke neurologist named Rothwell. It was UK, and he was bottom line, very critical of surgeon-reported stroke rates, the implication being that we were too stupid, we couldn't identify a stroke. My question is, there are a couple of questions in there, and ultimately I'd like to know how you confirm the methodology of stroke entry into VQI, for example, at these different sites, and have you been able to see, A, is it done by a specific abstractor, or is it done by the fellow or the resident? And then lastly, can you give us any information about audits that may have been done where someone goes back and looks at what was reported at their VQI site, and then actually how that correlates where you can dig into the charts and see if there was a correct abstraction. So I'm asking about methodology of VQI and how that might change, and then also how we could validate what a stroke is. I'm not sure what a stroke is. Sometimes, you look at them and, did you have a stroke? And it's not clear. Please, go ahead.
Thank you for your question. So in VQI, the outcomes in hospital outcomes are assessed by the treatment team. So they may be entered by the surgeon.
Right, the cleaning service or the intern or the fellow. You don't know who
enters. No. So I think that's one of the problems. I agree. And for your second question, VQI has audits in improving data accuracy. I'm not sure if the audits especially are focused on stroke capture, but I think we should focus on data accuracy in VQI and NISQIP and NIS. Thank you.
Dr. Aburama.
That's very unusual. I mean, I've been digging for carotid for over 50 years, and that's a great new concept. But the question now with the CMS asking us to explain to the patient the pros and cons, how do you tell the patients to tell them, well, your stroke / death ratio is so and so? How do you come out to the real terminology? I'm a bit confused. If you can elaborate on it.
Let me take this one. So we're not thinking that this is something that we would even discuss with patients. This is really a tool to evaluate the database that you're looking at. And if, like in NIS, it tells you that 98% of the patients are asymptomatic and 1% of them are having strokes while 5% are dying, it tells you NIS is screwed up and we shouldn't be using it. And that's the take-home message here. We should stop doing studies with NIS, and we're guilty of it too. We didn't put it up there, but we've done studies where we used NIS to determine symptom status and postoperative stroke. And it's a mistake. Please don't do it anymore. And this is just a mechanism where we can look at, if someone reports, oh, in our institution, our stroke rate was -3%, but our mortality rate was 3%. Well, you know that there's something wrong there. And so that's really the point of it.
Just one follow-on question. How would you suggest that VQI or other entities use this as a way to scrutinize their own data? I think for NIS, it's administrative data, but VQI is sort of purpose-built for clean data in this regard.
Yeah, I think the stroke to death ratio is is good for comparing different data sources, and I think VQI and ISGRIP are kind of comparable, but I think this can certainly be used to improve data accuracy for VQI and maybe improve audit mechanisms too, for better stroke capture.
Thank you.
Thank you.
Okay, our next paper, we're actually just sitting in Dr. Schermerhorn's lab meeting this morning, is predictors of postoperative stroke after transfemoral carotid artery stenting, presented, I believe, by Dr. Karen.
Thank you for the opportunity to present our work. We have no disclosures. TFCAS was approved for high-risk patients in 2004 following the SAPPHIRE trial, which showed non-inferiority compared to CEA, although subsequent trials had conflicting outcomes. More recently, the CREST trial did show non-inferiority. However, that was with regard to stroke death MI, while the stroke rate in that trial for CAS was significantly higher than that for CEA. In fact, one common criticism of many of these trials is the use of a composite outcome as their primary outcome, although strokes have a much higher impact on quality of life than MIs. Regardless, CMS approved for the use of TFCAS in standard risk patients in October 2023. As part of this decision, and as previously alluded to, part of that required a shared decision-making process between surgeons and their patients regarding procedure selection. However, there is no currently available stroke prediction tools that have been validated for the use in TFCAS. As such, our goal was to identify predictors of stroke risk for patients undergoing TFCAS using the VQI. We included all patients from 2011 to 2024 who underwent procedures for atherosclerosis. We then built a standard regression model to identify factors associated with stroke risk. We then streamlined that model and were able to use tenfold cross-validation to both ensure the robustness of our model and then calculate variable importance scores, which were used to build a point model which could then predict the risk of stroke for patients undergoing TFCAS. Using standard regression tools, we found several important mediators of stroke risk. These included age greater than 75, a preoperative stroke, uncontrolled hypertension, while use of DAPT and ACEs and ARBs were protective. We also found several important anatomic mediators of stroke risk. These included contralateral occlusion, severe calcification, and distal tortuosity, as well as arch type. Prior CEAs were also notably associated with increased risk. We also found that center volume was a mediator of risk, as was the urgency of the procedures. Using tenfold cross-validation, we were then able to identify predictors of stroke risk. The most important mediators are shown here, with uncontrolled hypertension contributing the most. Using the variable importance scores, we then assigned points for each factor and were able to test this model against standard regression. We noted only a 2% reduction in the accuracy of the point model compared to a full regression model, and that's highlighted in green. We then divided patients into quartiles based on their risk score and found that with increasing quartile, there was an increasing risk of stroke. We then were able to internally validate this by comparing what was expected based on our model based to what was observed in the VQI and found excellent overlap between the two. So in conclusion, we identified several important mediators of stroke risk after TFCAS. We were also able to build a point system that more simply predicts stroke risk, and this can be useful in the shared decision-making process and hopefully can help improve our patient selection. We found several important medical factors, including age, uncontrolled hypertension, and preoperative stroke, although many of the traditional risk factors that would deem a patient high risk were less impactful. We also found that anatomic factors had a significant contribution to stroke risk, and these should be very carefully considered prior to deciding on this procedure. Thank you.
Okay, this paper is open for discussion. Dr. Hingorani.
Just a quick question. Did you say CEAs were associated with a higher stroke risk?
Lower.
Lower. Okay, thank you.
And if I didn't, I misspoke, but yeah, it's lower.
Yeah, I think if I had taken an exam and asked me which of these are going to be associated with a higher stroke risk, I think I would have gotten everything right, except the one I think you listed was prior CEA is associated with a higher stroke risk transfemoral, and I don't quite get that. I thought most results show it's a lower stroke risk because most of the time it's intimal hyperplasia and you're less likely to embolize. So is that just an artifact and a problem with a retrospective EQI study, or is that real?
I think there's no way to know for sure. It certainly is a bit contradictory, and I agree that it very well could just be an artifact of the retrospective nature of this. Unfortunately, we have no way to say that with 100% certainty.
Good morning. Nice presentation. Joe Naum from Houston Methodist. Did you look at severity of the carotid stenosis or carotid burden, the amount of calcium or irregularity within the carotid as a predictor? Because we know from TCD that, going through the arch, if there's a lot of calcification through the arch, you're going to get emboli. And the moment you cross the lesion, you're going to get embolization. So does it make a difference whether the lesion is 70% versus 90% or super tight?
So with regard to the degree of stenosis on the procedural side, it's a little bit difficult to tell where this is retrospective. Most of the patients fit within the criteria of, greater than 50 or greater than 70. So where most of them lie in that range anyway, it's a little bit tough to draw any conclusions. With regard to the other anatomic factors, arch atherosclerosis, calcification, all those things, within the limits of what was available in the VQI, we did analyze that. I will note, we found many of these anatomic factors played a role, and there is a high degree of missingness within the VQI, and there is also an option for unknown with all of these variables. So I think they probably even have a stronger impact than what we saw, but unfortunately, we weren't really able to, prove that.
Mo Islami from Charleston. So given the last presentation from the same group, and since you have to have numbers to create a risk model,
yes.
If you have to use what you found from the last model, is it going to change the current model? The last presentation, is it going to change your current model or not for the risk factors?
I think in some degrees, yes, but while my colleague highlighted all the issues with using retrospective data in general, I think that most likely the strokes that are being captured are real. We're probably missing minor strokes in the VQI, and so that may play some role in changing our risk factors, but I don't think that it would have a significant impact. Again, but it's hard to say for sure.
Hi, this is Adele Hernandez from Orlando. Excellent presentation. I just think in the era of TCAR, we should now really be doing a lot of transfemoral stenting. My question is, did they use a filter, and what type of filter? And was these strokes disabling strokes, or were they just incidental events on TCD or something like that?
Unfortunately, because this is a retrospective data set, we don't have details about what filters were used or if they were used. With regard to the degree of stroke, again, the only real indication we have of that is a postoperative Rankin score. But again, the missingness there is a problem to draw conclusions. There is an old variable that used to delineate major versus minor strokes, but that was discontinued.
Okay, thank you.
So.
Thank you. Nicely presented.
Thank you.
Our next paper will be Safety and Feasibility of Same Admission TCAR Prior to Heart Surgery for Patients Presenting with Concurrent Severe Carotid Artery Stenosis and Surgical Cardiac Disease. This will be presented by Brittany Landavazo.
Good morning. My name is Brittany Landavazo, and I am a third-year medical student at Texas A&M School of Medicine. We would like to thank SCVS for giving us the opportunity to present, as well as Drs. Lee and Tracy for reviewing our manuscript before this. So to begin with, up to 50% of patients present with concurrent critical coronary artery disease and carotid artery stenosis as part of their initial workup. The optimal treatment of these patients has been long debated, with open carotid revascularization generally reserved for those with severe symptomatic carotid disease, which would preclude cardiac surgery. In this scenario, the role of less invasive carotid artery stenting, in particular transcarotid arterial revascularization or TCAR, remains controversial and is not yet well studied. So here we present our outcomes and methodology for treating severe carotid stenosis with TCAR prior to cardiac surgery. We conducted a retrospective chart review of 656 TCAR procedures from 2013 to 2024 and identified 15 patients who underwent TCAR prior to cardiac surgery during the same hospital admission. Our primary endpoint was 30-day stroke and myocardial infarction, and secondary endpoints included operative time, cranial nerve injury, neck hematoma, arterial dissection, total length of stay, and death. Of the 15 patients identified, 73% were male with a median age of 66. 80% were asymptomatic and 40% had bilateral carotid stenosis. Other comorbidities included congestive heart failure, end-stage renal disease, prior neck surgery, and previous carotid endarterectomy. All patients had greater than 70% stenosis, with the majority having greater than 80%. All 15 patients underwent coronary artery bypass grafting for coronary artery disease with indications as listed. These patients were selected for same admission TCAR and cardiac surgery because they were either symptomatic, had bilateral carotid stenosis, or their lesions were identified as high risk, which would place them at risk for perioperative stroke. 86% of the cohort received general anesthesia, with 13% receiving local sedation. Median skin-to-skin operative time was 50 minutes, with 9 minutes of flow reversal time. The median time from TCAR to cardiac surgery was 2 days, and the median length of stay was 9 days for both procedures. The difficult part of this was maintaining adequate anticoagulation post-TCAR while facilitating open heart surgery, which cannot be done on long-term oral antiplatelet therapy such as Plavix. So the heterogeneous agreement was to use aspirin and either heparin infusion, short-acting IV antiplatelet therapy, or subcutaneous enoxaparin as bridging therapy with discontinuation of treatment at least 6 hours before cardiac surgery. All patients, or the majority of patients, were discharged on standard oral dual antiplatelet therapy and statin management, with some also discharged on direct oral anticoagulation. There was one patient who had an allergy to statin medication and was discharged on ezetimibe. And then there was one patient who was not discharged on non-aspirin antiplatelet therapy, but they were treated with aspirin, rosuvastatin, and rivaroxaban. Our primary endpoints of stroke and MI were 0%, and secondary endpoints were also 0%. Our initial experience with same admission TCAR prior to cardiac surgery suggests that it's reasonably safe and feasible. Severe cardiac disease should not be considered a contraindication to TCAR with general anesthesia. And while bridging anticoagulation strategies between TCAR and cardiac surgery have not yet been optimized, our experience shows that aspirin with either heparin infusion, IV antiplatelet therapy, or subcutaneous enoxaparin seems sufficient to prevent early stent thrombosis after TCAR. Thank you.
Dr. Aburama.
I wonder whether the attending is available for this question, because if you notice, 80% of your patients were asymptomatic. Is that correct? Mm-hmm. And the guidelines, which we just published, less than maybe 2 years ago, if you have asymptomatic carotid disease and you have symptomatic cardiac disease, you go with the cardiac. Don't worry about the carotid, unless there is specific circumstance, like, for example, occluded in one side, 90% on the other side, and you think that patient might not be a good fit. Then it depends on the experience of your institution, whether do them together or separated in the same day admission. So I'm just wondering what made you guys to pick these patients, unless you're not the one decided, someone else did. Yeah.
So Ron Turley from Austin, I'm the senior author here. Great question, and this is a very well done, but kind of the epitome of a retrospective study. And this is a heterogeneous experience of a multidisciplinary group, about 20 vascular surgeons, cardiac surgeons, and we all have different practice patterns. There are some cardiac surgeons who are by the guideline. I don't care if you have a 99% string sign. If you're asymptomatic, I'm going to do your heart first, and you can fix the carotid afterwards. We had some other cardiac surgeons a little bit more nuanced, and these patients were all kind of over a long 10-year time here and there, usually in the setting of a cardiac surgeon had a concern about a high-risk patient. Usually they had either maybe not counted where some kind of concerning morphology, contralateral occlusion. But the guidelines is based on carotid endarterectomy. I think that the TCAR, our hypothesis of TCAR is less invasive, easier to heart, and this can be done in the same admission.
I just want to push back a little bit about one of your conclusions that it's safe to use these other options as bridging as opposed to the dual antiplatelet agents. You have relatively small numbers of 15 patients. If your 16th patient gets a stent thrombosis, I think your conclusion is going to be a little different. So my personal philosophy is I would not generally do a TCAR immediately prior to a CABG because most heart surgeons don't want to operate on Plavix. So if the indication is there, and I agree with Dr. Abarama, I would lean towards doing a concomitant carotid endarterectomy or maybe stage it. But anyway,
That's a rare point, and it's a 15 patient, and we want to continue looking at this. I think it needs to be further studied, and our cardiac surgeons will not do open heart surgery on Plavix or Brilinta or any long-acting, but we have 15 patients. Clearly, like a phase 1, is this terrible, a good idea? And the first 15 patients have done, pretty good. So, but we like to continue to look at this, maybe kind of follow us prospectively. For our practice patterns here in our group, it's nice to have somebody comes in who has a concerning lesion felt by our cardiac surgeon partners to be able to have a less invasive alternative. Our practice does not do simultaneous carotid endarterectomy. It's just not what we do in our practice.
I just want to say I did this once 23 years ago. The cardiac surgeons didn't want to put him on Plavix. I did it on the table with a C-arm. Kept him heparinized afterwards. He was awake during my carotid stent. That went fine. Then he went to sleep, had his CABG, and when he woke up, his stent was thrombosed and he had a stroke.
Mal, this is not pontificating. I have one question. Are there any patients who you did the TCAR intending to then proceed to cardiac surgery who then subsequently did not proceed to cardiac surgery for one reason or another? You may not know that.
No, not in our experience, because this was we actually looked for people who had TCAR, and then, at least in our review, we did not see that, no.
Thank you.
Okay, our next paper is Barriers to Routine Use of the Mini Incision CEA, Results from the SCVS Survey. This is from Dr. Dietzick and his group, and presented by Dr.
Vengatesan. Thank you. Good morning, everyone. Thank you for the opportunity to present our work. I have no disclosures. Carotid endarterectomy remains the gold standard for treating carotid atherosclerotic disease, exhibiting low morbidity and mortality rates. Mini-incision carotid endarterectomy, defined as MICEA, typically performed by incisions of max length of 5 centimeters, has shown numerous benefits as listed here. Despite this, many practicing vascular surgeons continue to perform CEA via traditional 10 to 15 centimeter incisions. This study aims to elucidate what factors preclude surgeons from adopting the mini approach. This was a survey-based study distributed nationally to practicing vascular surgeons who are SCVS members. There were a total of 14 questions focused on surgeon training, background, whether they perform MICEA, use of adjunctive measures such as patch or shunts, and what factors precluded them from performing the procedure. And the stats were performed as listed. In total, it was sent to about 1,100 SCVS members, of which we got 149 responses. 85% of these respondents trained in a conventional fellowship. Median practice time was about 14 years. 65% of respondents performed MICEA at least once. However, only 19% of them performed them routinely or always. Looking at the relationship between duration of practice and how frequently respondents perform MICEA, roughly half of them started practice within the last 15 years, and the largest number of respondents, about a third, have been in practice for 5 to 15 years. As you can see, there's no clear correlation between the two, as roughly a third of respondents have never performed MICEA, regardless of practice duration. Looking at training type versus frequency, we again see that there seems to be no obvious correlation between the two, as again, roughly a third of them have never performed the procedure, and about half of them have performed it at least sometimes, regardless of training type. Looking at whether they were taught the procedure in training, we see some more notable differences, as only about 31% of respondents were taught the procedure during their training. However, about 22% of them who were taught the procedure continue to not perform it. However, this is compared to 39% of those who were not taught the procedure in training. This trend was statistically significant. Interestingly, about 18% of respondents who weren't taught MICEA in training also stated that they performed the procedure always in their practice, and we sought to examine why. We then looked at whether having partners who performed the procedure influenced the responses. We found that among respondents who did not learn MICEA in training and did have a partner who, did not have a partner who performed it, 49% of them never do MICEA themselves. However, among respondents who did not learn MICEA but did have a partner who performed it, only 8% of them never do it themselves, and the difference was significant. This suggests that having any opportunity to learn MICEA increases likelihood of performing the procedure yourself in practice, and it appears less likely to be self-taught. When looking at frequency versus belief about whether the procedure gives adequate exposure, 100% of respondents who always perform the procedure disagreed that it does not provide adequate exposure, but 84% of them who never perform the procedure agreed that it does not provide adequate exposure, and the overall trend was statistically significant. Similarly, looking at frequency versus belief about whether patients care about incision size, 71% of respondents who always perform the procedure disagreed that patients don't care about incision size, and 82% of those who never perform the procedure agree that patients don't care about incision size. The trend was statistically significant here as well. In conclusion, duration of practice and type of training do not seem to be correlated with frequency of performing MICEA in practice. However, learning how to perform the procedure, either in training or in practice with a partner, significantly increased the likelihood of performing the procedure yourself. Additionally, an important reason that surgeons do not perform this procedure more routinely seems to be because they believe it does not provide adequate exposure and patients don't care about incision size. This study does have some notable limitations. It is a survey-based study with a low response rate. It was also only sent to SCVS members, potentially missing out on other surgeons who are not SCVS members or members of other societies. And lastly, there is some ambiguity into the definition of sometimes and rarely used in the survey questions themselves, which could lead to increased variation in the responses. Thank you. I'll take any questions.
Great. What do you think the learning curve is for this, for folks that didn't get trained to do that? Like if they went out into practice and decided they wanted a more cosmetically appealing, or it was a short squat neck or something where maybe there are advantages from a wound standpoint.
Yeah. I anticipate the learning curve is for performing the procedure for someone who knows how to perform endarterectomy. I anticipate it's probably not that significant. That being said, people who have not been trained in it and did not have a partner to teach them did not perform the procedure, so it might actually be more of a barrier than we expect, but we didn't look at that specifically.
Yeah, good question. I think that, today there are so many available videos on how to do the procedure. I think it is, a little scary the first time, but it really is not hard to learn.
One more question, Dr. Chair.
Thank you for sharing this with us. And having some discussions with our trainees who move on, to other institutions, what they practice in their first 5 years may not be exactly reflective of what they were trained to do, just because of local practice patterns, what their senior partners do, and so on. How would you suggest that someone would navigate this? Someone is, perfectly trained to do this procedure, but their partners at their new institutions don't. So how do you navigate this, knowing that it's not the norm at their new institution?
Yeah, I think that's a difficult question to answer. I think if the respondent is trained into doing the procedure themselves and feel comfortable with it, again, we've seen the benefits of performing the procedure, so I think they would have to do it. Whether or not they are available to teach or to help their partners who don't perform the procedure would be another thing to look at, but I think you have to try.
Yeah, again, these are questions that would be very hard for Carotid, who is a fourth-year resident, to answer. But I think that, it all depends upon what kind of partners you have. If they're willing to learn something new, or if they're going to be the kind that tell you that, listen, this is the way we do it, and that's the way we're going to continue to do it. And so they lose the advantage of what someone coming out of training who's trained to do it brings to the practice, and that's unfortunate.
Final question, Dr. Abraham.
Yes. I've done probably some of these in my first 10 years of practice, but I have done literally none in the last 30 years for two reasons. I always preach to my junior faculty or residents, this procedure has to follow what we do with cancer surgery. No touch technique. I don't know how the hell you're not going to no touch with 3-4 cm lesion, 3-4 cm incisions. So my point to you is, you're really probably compromising outcome in the future, particularly, let us say, lesion is long enough. And how the heck do I know I took all the lesions? Have you really had data several years later, the restenosis rate is less or more? So my point to you, I would love many incision under select group of patients. Otherwise, to do it for everybody, I think you are pushing your luck. I hope you will answer us.
Yeah, again, I think that that's really a misconception about this operation. I think the exposure is great. I think the key is dividing the platysma muscle, and once you divide the platysma muscle beyond the skin incision, you can move that incision a number of centimeters up and down with just a retractor and not having to touch, as you stated, having to touch the carotid, possibly cause embolization before you're ready to clamp and get all the plaque. So that has not been an issue. I think it's just really learning how to do it.
Thank you very much. Nicely presented. Our next paper will be Direct Supply Cost and Complication Analysis of Transfemoral Carotid Stenting versus Carotid Endarterectomy versus Transcarotid Artery Revascularization, a single-center retrospective study, presented by Sarah Wenyan.
Thank you for the opportunity to be here to present our work. I have no disclosures. So for our introduction, carotid artery stenosis is a well-known cause of ischemic strokes, as we know. 138,330 individuals experience ischemic stroke secondary to carotid artery stenosis every year. Our three main interventions for treatment of carotid artery stenosis are TCAR, carotid endarterectomy, and then transfemoral carotid artery stenting. While carotid endarterectomy is the accepted gold standard, TCAR is becoming more widely adopted. This is for a few different reasons, including increased studies showing efficacy, but also could be secondary to recent policy advancements that have encouraged the adoption of TCAR, including in 2015, the FDA approved TCAR for carotid artery stenosis in standard risk patients. In 2022, Medicare and Medicaid services approved TCAR for approval within the VQI TCAR surveillance project. So for our objective, with the increased adoption of TCAR, as well as policy advancements to encourage adoption, it is essential that we reevaluate how TCAR compares to transfemoral carotid artery stenting and carotid endarterectomy, both in terms of complication rates and financially. A few studies have attempted to compare the cost-effectiveness of TCAR compared to transfemoral carotid artery stenting and carotid endarterectomy. However, mixed results have been produced. Some studies indicate there is no significant difference in cost between TCAR and carotid endarterectomy, and others state the exact opposite. So for our methods, we completed a retrospective chart review analysis of all patients who underwent transfemoral carotid artery stenting, carotid endarterectomy, and TCAR between January 1st, 2016 and December 31st, 2024 at 3 different Thomas Jefferson University hospitals. We had 3 primary outcomes, the first being direct supply costs, second, total account charges, and third, length of stay. Our secondary outcomes were short-term outcomes between procedure type, as well as cost variation between symptomatic and asymptomatic patients prior to surgery. So for our results, as you can see when looking at the pie charts here, at our institution, neurosurgery performs 91% of all the transfemoral carotid artery stenting cases, while 74% of the carotid endarterectomy cases are performed by vascular, and 95% of the TCAR cases are performed by vascular surgery as well. Now, when specifically looking at which surgical service performs interventions in a greater number of the asymptomatic patients versus symptomatic patients, you can see in Figure 2 that neurosurgery leads in symptomatic cases, while vascular surgery leads in asymptomatic cases at our institution. The next data point we wanted to evaluate was how the length of stay and average total charges differed between the symptomatic group and the asymptomatic group. We found that at our institution, as you can see in figure 3, that the symptomatic group had a greater average length of stay than the asymptomatic group, and figure 4, you can see that the symptomatic group had a greater average total charges than the asymptomatic group. In summary, symptomatic patients are more costly than asymptomatic patients at our institution. The next data point we wanted to evaluate was how the mean length of stay and mean total charges were compared across all 3 procedure groups. We found that transfemoral carotid artery stenting has a significantly greater length of stay and mean total charges than both carotid endarterectomy and TCAR. But if you look at between carotid endarterectomy and TCAR, the mean length of stay and mean total charges are not significantly different. The next point we wanted to evaluate was we wanted to dive a bit deeper into our charges and specifically look at direct operative supply charges. As you can see in figure 5, TCAR has the greatest direct supply charges with transfemoral carotid artery stenting following, with carotid endarterectomy being the least expensive. The next factor we wanted to look at was how the 3 procedure groups compared in terms of short-term outcomes. We found that at our institution there is no significant difference between the 3 procedure groups in terms of short-term outcomes. So for our conclusions, transfemoral carotid artery stenting was the most common intervention for symptomatic carotid artery stenosis. This can be explained by Jefferson being a stroke center. At our institution, the neurosurgeons are the ones intervening for strokes secondary to carotid artery stenosis, and they're mainly performing the transfemoral carotid artery stenting. Supply charges were greatest for TCAR, followed by transfemoral carotid artery stenting, with carotid endarterectomy being the least expensive. The mean total charges of symptomatic patients exceeded asymptomatic patients, secondary to the increased length of stay. Next steps for us include further sub-analysis between the symptomatic and asymptomatic groups and evaluation of longer-term outcomes. Thank you.
Dr. Dietzig.
Nice presentation. But I'm curious, in the transfemoral, you said most of those are done by the neurosurgeons, and I imagine that's in the setting of stroke salvage. So how did you look at the stroke rate in those patients? How did you know what the stroke was from? Because usually they're doing something at the carotid bifurcation if they can't get into the head. Was that the same here?
You mean for like follow-up, like stroke incidents after the procedure?
Yeah.
Okay, so for those, we specifically went through every single chart, and I read all the notes to see when the stroke was categorized by year. So we were able to see, I knew if they were symptomatic on presentation, and then it was if new symptoms presented that were different than the original symptoms. So there was a different incidence of symptoms.
So these were not done as emergencies to salvage a stroke patient with an intracranial. In other words, how many times did they try to take intracranial clot out to salvage a patient from a stroke, and at the same time have to do a carotid stent? Was that part of?
Sorry,
am I missing?
Those patients were excluded. The ones
They
that
were.
had combined
Okay.
carotid stenting and intracranial procedures.
Okay.
But the data is obviously, and there's some further sub-analysis that we still have to do on this data because we realized we had mixed the asymptomatics and symptomatics a lot, so we're going to do that.
Misty Humphreys, I want to expand on that question because I'm not sure that I'm as satisfied with the answer. So you're saying that you excluded all patients who had a concomitant stent and procedure at the same time, but what was the time duration between when they may have had an aspiration procedure for an intervention and when they had their carotid artery stent from the neurosurgery group? And you also mentioned that you looked and saw by year, but we're talking sometimes days between when they're done. And so can you expand on whether or not any of the recurrent symptoms or strokes had anything to do with patients who had aspiration, or did you just exclude everybody that had aspiration?
Yeah, the people who had procedures in the brain were excluded, so those were not in the study.
Will Robinson, Springfield, Illinois. Really nice job, nice presentation. My question is, have you taken this data to your administration, and what's their response? Basically, this is something that we all deal with. This is physician-centric care, not patient-centric care when you see one group offering one procedure and another offering another? We all know that transfemoral stenting for symptomatic carotid stenosis is inferior to either CEA and TCAR, except in unusual circumstances. And you have probably a so-called collaborative group with you who does that 98% of the time. I ask because we all battle these issues, and I'm wondering what you said to administration and how they responded.
I'll answer that, sorry. We have not taken it to the administration, but that's a good suggestion. I know that a lot of times administration does not care about certain things, and turf battles become issues, but those are much more complicated issues to deal with, but good point.
I think you can take these slides with a few of the slides about the randomized trials of carotid endarterectomy and stenting, and I'd be interested in their response about getting to the best patient care. I mean, this is fascinating. We all know this happens, but you guys got the data to kind of elucidate just how drastic the procedural differences are between specialties. And it's a real challenge. So I think you guys have a great opportunity to do that.
Yeah, I think the neurosurgeons haven't really come up with the times, and they haven't really adopted TCAR, which I think is an excellent procedure.
Dr. Jordan.
Will Jordan, Medical College of Georgia. I wanted to shift the question a little bit because I understood you were doing more of a financial analysis on what the costs were rather than looking at specialty differences. So my question is really, it'd be great if you could answer it. It's as much food for thought. If we have two different procedures that yield the same outcome or near same outcome, near complication rate, when do we start factoring the cost of the procedure into the decision? And I realized that the real difference that I saw in your cost was procedural costs in the OR. I know you had charges that were very broad and essentially equivalent, but most of the data is going to tell you that you can get more for less money if you do the endarterectomy compared to the stenting procedures. And I think that one old vascular surgeon said that the vein never took him to dinner, and so I wonder how much we're promoting these stent procedures based upon our industry partners and their promotion of it. So would love to hear your thoughts on that.
This is a difficult question to answer. In all honesty, I personally perform more carotid endarterectomies than stenting because I truly believe in that procedure. I think, you clean out the artery and it's a beautiful procedure. We do perform some carotid stentings, and I think stenting has a role, and I know some places have adopted it much more prevalently than we have. But I guess the other point is that it's also specialty dependent. As vascular surgeons, we do a lot of carotid endarterectomies. If you look at the neurosurgery data that we have, they do mostly stenting.
Yeah, I'm going to go back and ask it again. At some point, if you're going to get the same result, why not do it for what's less expensive? I mean, eventually we're going to have to answer that question. That's all. Thank you.
Thank you. Okay, next I'd like to invite our president, Jean, to come up to announce the Peter B. Samuels Award for this year, which is annually given to the best paper.
Thank you, Jason. So the Peter B. Samuels Award is being awarded to Priscilla Tenemal from LSU for her paper entitled Management and Outcomes of Traumatic Carotid Injuries. If I could ask her to come up here. There she is.
Perfect. Thank you so much.
So she'll give her talk now, and then this will be the last talk on this session. Thank you.
Thank you for giving me the opportunity to present, and it is an honor to receive the award.
We have no disclosures. Traumatic carotid injuries have significant morbidity and mortality. Blunt carotid injuries have a stroke rate up to 50%, and when appropriate, medical management, such as anticoagulation, has been shown to be safe and effective for stroke prevention. Penetrating carotid injury has a mortality of up to 10 to 22%, and repair is generally indicated in all symptomatic patients suffering from penetrating injury. Due to the variability of presentation of these patients, there are no clear guidelines for management. So our objective was to report outcomes of blunt and penetrating carotid artery injuries and investigate risk factors for stroke. We performed a retrospective review of a prospectively maintained Level 1 trauma center database, and we identified patients 18 years and older with traumatic common and internal carotid injuries from 2010 to 2021. Univariable logistic regression analyses were performed to identify the variables that were associated with stroke. A total of 86 patients were included in the study with a median age of 31 years, and these are their demographics. Neurologic status on arrival was assessed using the documented Glasgow Coma Scale or focal neurologic deficits in the notes. The median GCS of our patients was 13. 53% of our patients presented with penetrating injuries, while 47% suffered from a blunt trauma. And the majority of our patients had internal carotid injuries, and there was a small portion that had both internal and common carotid injuries. The most common injury characteristics that were noted were pseudoaneurysm, intimal injury, and dissection. And the majority of our patients underwent non-operative management. Among those who underwent operative management, 27 underwent open repair with either interposition, vein patch, ligation, or primary repair or shunt, and 10 underwent endovascular interventions, either stents or embolizations. 20 patients suffered a stroke, and 23 patients died during the hospital stay. Now, looking at our risk factors for stroke, we found that mechanism of injury was not significantly associated, and neither was intervention, non-operative or operative. What we did find significantly associated was presence of the avulsion or transection of the artery, as well as a GCS of less than or equal to 14. There were few patients who presented with the GCS of 15 who ultimately had a stroke. So out of the 30 patients who presented with the GCS of 15, only 2 had strokes, and both were patients that suffered from a penetrating injury. We had 51 patients document follow-up at a median of 4 months, and only 8 had residual deficits from their carotid injuries. To conclude, stroke was not significantly associated with mechanism of injury or management, and carotid injury has a significant risk of stroke if presenting with an imperfect GCS, and patients who present neurologically intact rarely deteriorate. Thank you.
This paper is open for discussion. Have you found any difference, the ones that sort of had to really emergently go to the operating room versus ones that had their other trauma issues sorted out first? Because I think sometimes we're forced to go because something's bleeding out while something else is bleeding out, versus we stabilize the abdominal, pelvic, orthopedic issues, and then maybe in 48 hours we go.
Yeah, I think I found that those who needed to go emergently for repair for the carotid injury, I was noticing a lot of those there was a higher mortality in those patients, and the ones who, it was some of the patients who had
multiple injuries. Ultimately, they also died, but later on in their hospital course due to multi-system organ failure.
Congratulations on the award. Very nice paper, very important subject that we all deal with. In my practice, majority of my carotid trauma is blunt, with the majority of it being dissection. And can you elaborate a little bit on what y'all's experience has been at LSU with surgery or endovascular options in a dissection, and maybe your attending can elaborate on that, if there's a difference, and what y'all's treatment paradigm for that is?
Yeah, I'll take that one. It's so if you look carefully at the results here, one of the things that kind of is corroborated, which most of us know, is that if you have a stable patient, neurologically intact, with an intimal dissection that doesn't look flow limiting, medical management is safe, because we had none of those patients ended up with a late stroke up to it's trauma, so it's limited database, 4 months follow up, but medical management and traumatic dissection seems to be very, very safe, which, it's hard to get from the literature. One of the important parts of this is that the trauma databases are so poor at really abstracting data, meaningful data from, and even our own trauma database. This all had to be corroborated with chart reviews and things like that, because ICD-9 codes really didn't differentiate external carotid from internal carotid injuries, so obviously very, very different potential outcomes there. So that's really why we did this, is we don't know what the right answer is in so many of these patients because the literature is so kind of heterogeneous.
I just want to clarify, you found no differences between the outcomes between open and endo intervention. Is that correct in terms of stroke?
When we looked at the risk factor intervention, we stratified between operative intervention versus non-operative, but I don't think we further looked into open versus endo.
Yeah, there are only 2 strokes total that after presentation. So it's hard to really kind of, and both those look like they were huge injuries that probably had some hypotension. And
all right.
I have one quick question. Mal, the endo, was that for blunt or for penetrating?
I believe all of our stents were in penetrating for dissection. I don't believe we stented any penetrating trauma for that, because all those had neck exploration. So
yeah, for the blunt. Mm-hmm.
Yeah.
And then how did you treat a grade 4? So if it was thrombosed?
Yeah, not a lot of those, unfortunately, because that's one of the things we're trying to answer. But basically, if they came in any kind of window, they were treated, although we just had one recently that's not represented here that was not treated, and seemed to do fine. I think, that's the question, is if they're thrombosed, how long are they thrombosed? And then are we supposed to extrapolate from carotid, elective carotid literature on thrombosis? And nobody knows the correct answer to that. Our general paradigm is if we can get them in a reasonable amount of time, we'll do the thrombectomy and do it. But even that is not a lot of cases. I think, again, what we can say is that patients don't tend to devolve once they get to you. Whatever they present with is generally what they kind of end up with. And so it's, we just keep this and keep on keeping on, but we've definitely not resolved that issue about the thrombosed carotid.
You're in the right seat, Dr. Sheehan. Keep on keeping on. Congratulations, and nicely presented. I'll now invite Dr. Vincent Rowe to the stage to introduce our president, Dr. John Bismuth, for his presidential address.